today we are, my name is Emma, let's start there. And I'm now a fourth year medical student. I will be talking a little bit today about mood disorders. I know that that's a little bit different than our, typical one. I'm excited about the psychiatry itself. I won't be applying to psychiatry, but I think it certainly blends in with a lot of different specialties. Regardless of the specialty, I think it kind of bleeds into it. So we'll be talking typically about mood disorders. We won't really be talking about psychotic disorders, so not so much about schizophrenia, though if that is something that I can always on that another time. I think schizophrenia is very interesting, and once you've seen a patient of whom is schizophrenic, forget it, much like many other things in medicine. But today we're going to be talking about mood disorders. I think that is important, and if you can recognize that and help somebody, you may be able to change their life. Being said, don't forget we have a YouTube page. All of our go onto the YouTube page. Is something, or you're like, Emma's so funny, she said the best joke ever. You could always go back and watch it, or tell friends, whatever. So those are all posted to our YouTube page. Please go to the page, subscribe, like our videos. We would love all of that. But don't forget, if you miss or you can't come to a session, you can certainly still get credit by watching it later. So I have a recommended read for you. This is a little bit different than all the medical reads that I usually have you guys reading, and I hope you guys are in fact reading these. The last two were shorter reads. This one is a little bit longer. It's a whole book. It's by a comedian. I don't know if you guys are familiar with Jacqueline Novak. She is a comedian of whom has a great podcast. It's called Poog, P. I listen to it pretty religiously when I used to drive. Now I don't drive, I'm studying for boards. But at any rate, in her book, she talks about her own battle. Mind you, she is a comedian. Maybe some choice words in this book. I haven't read the entire book. I've read part of it. So keep that. But she does talk about her own battle with depression and kind of, allows a different insight to it. Other than that, I think it's always to know the suicide prevention hot Lifeline that you can call, whether it's you or a friend or else. Nobody's too good for, so always that. A lot of people have been through depression. I can attest to that myself, and I think it's important that anybody gets help with it, so always. Okay, so here's my joke for today. But while you guys are reading this, our poll, let's bring that up. Let me launch this for you. So very similar to the other polls that we've done before and after. Put a little bit into the poll here to see where everybody kind of stands with mood disorders. All right, so that's 30 seconds. Let me share this with you. So a few of you said I know nothing. That's okay. We're here today. Some of you said I know a little. Some said I know. Nobody said they know a little. So let's see if we can't do that specifically. And then kind of along those same lines, structure. We're gonna change it up a little bit. So from what you're used to from me specifically. Usually we'll go through one specific case, kind of really dissect that. But what we're going to do a little bit different than what you're used to with me is we are going to kind of change it up a little bit. We're going to do two cases today. I thought I would be doing you a disservice if we didn't, at least cover more ground with mood disorders, especially because it's pretty interesting. So we're going to have 2 cases, and what we're going to do is we're going to really present the case, go through the differential, go through the assessment and plan, go through the pathology, then go into the next case. So you'll kind of have everything all at once for one case, and then everything all at once for the next case. As always, your guys' role, please participate, ask questions, and then be sure to fill out your SOAP note throughout the presentation. And since there is 2 cases, you choose which one you want to write the SOAP note for. If you want to, get it out of the way and use the first case to do that, perfect. Then you can kick back and, enjoy the rest of the presentation. If you're a procrastinator or want to do it the second one, feel free to do the second one. But remember, you have to do, one in order to get credit to get to the quiz, to submit it and get credit for the session. Okay. All right, and here's our form. Becca had put that into the chat. She also emailed you guys the link. So those of you that are not very good at paying attention to your email, go back to your email and see if you can't find that. It's also in the chat as well. And remember, the subjective part, what we're looking for is the HPI, so things that the patient is telling us. ROS, those are that's a review of systems, so pertinent positive symptoms and pertinent negative symptoms. Then the objective part is the vital signs in the physical exam. Those are the information that we are producing. The assessment, that is part of our differential diagnosis. And then the plan is going to be how we're going to rule in or rule out or treat the different differentials that we have on our list. I have a video for you here.
Tell me something about the events that took place prior to your admission to the hospital.
Okay, it was 4 o'clock in the morning. I was working out for the Olympic team. Can you dig it?
Why were you doing that?
Because, I had this buddy who got thrown out of the place where I was living, and he was supposed to meet me in Hallsville Park. And it was 4 o'clock in the morning, and he didn't show up, so I figured that I would work out. And then they got me on a DOC, disorderly conduct, question mark.
What were you doing when you were working out?
Running back and forth, basically checking out the court, checking out the moves that I'm going to do when I get into the Olympics.
Are you already on the Olympics?
No.
You're not on the team?
No, I'm not on the team.
So you're just trying out. Is that what you're trying to do?
Yes, trying out.
What makes you think you'd be eligible for the Olympics?
Because I'm a damn good basketball player and I had never done nothing wrong in my life before. So I think I can make the Olympic team.
Why do you say that?
Because I'm in good shape and I got Olympic abilities. I know I have. Olympic basketball skills. I know I got Olympic basketball skills. I'm better than Oscar Robertson.
Earlier, you said you could join the Olympics because you'd never done anything wrong and you were in good shape.
Like nothing I'd be ashamed of. See, like nothing I'd be ashamed of. Like if I did something wrong that I'd be ashamed of, I think it'd be hard for me to join the Olympic team. Don't you believe?
What do you think about all those fights you've gotten into ever since you were in 7th grade?
Oh, that was just elementary, I mean, that's nothing big. I mean, that's just hassles between elementary kids. I mean, what's that? I mean, maybe I got a SWAT here and there for punching a kid in the face or something. That's nothing big. All right, let's go on.
So what happened when you were 17?
What happened when I was 17? I was committed to a mental institution. It was a bummer. I amaze myself sometimes.
Why?
I guess it's my personality. I don't know. I'm something else, aren't I? All right, let's go on.
I lost my train of thought. Do you have any plans for the future?
Well, I've also been thinking about becoming a free agent and see what Bobby Leonard thought. What kind of skills he thought I had. See, he's the Indiana Pacers coach. See, I'm a free agent now, and really that's being a nobody. Nobody's looked at me yet. Leonard hasn't. Nobody has. I was going to have my dad get in contact with Leonard, and if it's a possibility that he could do it, because I'm a damn good basketball player, and I should be on a professional.
Have you played basketball in the past?
Yes, I played basketball all my life.
In school? Were you on the high school team?
Yes, I was on maybe the 8th, 9th, or 10th. I don't know. It's been so.
So you didn't play varsity?
No, I didn't play varsity. I dropped out. See, like I got married when I was 16 or 17.
How were you feeling when you were playing basketball that night? How would you describe it?
I was feeling great. Fantastic, super. It was like the best feeling in the world, or next to the best feeling in the world.
What's the best feeling in the world?
I don't think you want to know that. All right. I'm getting a little bit cramped.
You can walk around.
All right.
All right, guys. So that is our first patient there. I do have a vignette for you as well. So a 33-year-old male presents with his family due to erratic behavior and disruption at home. The family reports that he is rather distracted, will start one task without repeating it, and is constantly talking. He has been noted to sleep less than 3 hours on average for the past 1.5 weeks, so about a week and a half. And states that he has been trying out for the Olympic basketball team and trying to become a free agent with the NBA. The family reports he has had an episode of depression 2 years ago, of which was treated with Celexa, so that's citalopram. Which resulted in elevated mood similar to this episode. All right, so my questions for you all. What are important differentials that we should consider right now? Think broadly. Sometimes it's hard to know, with psychiatric disorders. But remember, for psychiatric disorders, we definitely want to also include, we also want to rule out or rule in medical disorders. So we don't want to say, oh, this guy, obviously suffering disorder, so we want to be sure, we don't want to worry about medical stuff. So Trish said bipolar, absolutely, we want to put that on a differential. What else? Psychosis, ADD, sure. To rule out neurological things, yeah, certainly we would want to rule out neurological things. What else? He has high energy. What is something that we had talked about? I had presented on it, that can cause sort of high energy tachycardia, things like that. Mania for sure. Yeah, we can think about drugs, stimulants, sure. What about with the thyroid? Good, yeah, hyperthyroidism. We would want to, rule that in or out. When we think of, depression, we might want to rule out hypothyroidism. When we think of, elevated mood, things like that, we want to consider perhaps hyperthyroidism, or at least rule it out. Okay, good job. You guys are right on track for that. So we kind of touch on this, what medical etiologies, we can certainly think about a brain tumor, some different, if we're perhaps dealing with an older individual, we would want to think of, different kinds of dementia, like frontotemporal dementia, that really changes your mood and the way you interact. Hyperthyroidism, drug abuse, different psychiatric disorders for sure, whether that's bipolar, or schizophrenia as well. We can also consider that depending on what's going on. All right, so what elements of the history are important for us to kind of keep in the back of our mind? What was important that either the patient had told us or was in the vignette itself? Wouldn't a brain tumor be extreme? Well, you know, a lot of things are extreme, yes, but what if we said that, okay, it's extreme, and then we completely missed it. So the thing is, it depends. If this kind of was it depends on the story. It depends on, you know, how it's evolved over time. A lot of things are extreme, but you know, that's the thing about a differential diagnosis. It helps us kind of narrow in on what's correct. So let's see. Somebody said Celexa elevates the mood. Good. Yeah, exactly. Good. That's exactly something that we want to consider. Good. In a mental institution since 17. Yeah, that's what he told us. Had a depressive episode. Good. Had a history of depression. Yeah, that's what all you guys were pinpointing there. Good. Those are all pertinent elements of the history. I want to kind of really highlight that element of he took Celexa and then had a manic episode. So that's something to consider as well, because a lot of things, something very wise that a psychiatrist had taught me during my rotation was that a lot of times the pharmacology, the different drugs that you prescribe for patients will make the diagnosis for you. So keep that in mind as we kind of keep going. What questions should we ask before proceeding? So remember what we put in our mind for our differential diagnosis, and let's ask this patient questions that will help us kind of get more of a history to rule in or rule out some of these things that we thought of. So what other questions do we want to ask him? Good, yeah. Previous drug abuse or even current drug abuse. I think you're absolutely right, Hope. And how do we ask them that question while we're on? Do we say, do you do drugs, or how do we ask them? Any family history? Good, yeah, that's important to ask with psychiatric disorders. Sure. Any type of hallucinations? Good, yeah, we can rule in or rule out schizophrenia. So, and same thing with hallucinations. Do we ask them, do you have hallucinations? Do they know, are they able to, if they have schizophrenia or they have a delusional disorder, are they able to delineate whether they're having hallucinations or not? I know that's a hard question, but the kind of short answer of it is, as Parab kind of indicated, and as Hope is indicating just now, exactly, that's exactly what I ask. Do you ever hear voices, or do you see things that you know are not there? They're usually able to sometimes they have a good insight that things are there. A lot of times, if they hear voices, they know that they're not there. They're able to kind of delineate that nobody's there, or they're hearing those voices. So usually they have insight. Sometimes they don't, but that's a good thing to ask. Is that do you hear voices, or do you see things that are not there? And then along the lines of the drug abuse, usually I just ask, do you do any illicit drugs, or have you done any illicit drugs? And usually they'll you know, ask in a very non-judgmental way, they'll certainly disclose to you, especially psychiatric patients. They're usually very open. Ask about any headaches or vomiting to rule out a brain tumor. Yeah, good, exactly. And we'll want to ask about the timeline too, because as we know, with brain tumors, it doesn't happen overnight. You don't wake up with a brain tumor. And speaking of waking up, usually early morning headaches are pretty indicative of a intracranial tumor increasing the intracranial pressure when you're lying down, okay? Any past relationship breakup. Why would we want to ask that, Kay? Also check the fundus to see if their ICP is up. Yeah, certainly do that to see if they have papilledema. That would be indicative of increased intracranial pressure. So good job. You guys are right on track. I hope seeing this patient kind of ingrains the idea of what this patient has in your head. We'll revisit him again in the future. But let's work together right now. What findings from this patient's interview did we find that are significant? So go ahead and type them in the chat. Anything that you think is kind of significant from his interview. Can be little, can be big, whatever. Even just from his actions. You can find out a lot about a patient just by observing them. Pressured speech, good. Anyone else? Good. So I'll say high energy. And I think the laughter certainly stuck out when I watched this video for the first time. And the second I saw this video, I knew it would be perfect for you guys. Good. He has talkativeness. And the jumping from topic to topic, we can call that tangential speech or flight of ideas. What else? Yeah, so he does have some grandiosity. And what we mean by that is he's saying that he's, trying out for the Olympic team, and he, is, also going into the NBA, though has never actually played basketball from what it sounds like. So he's kind of just has these ideas that he can't do anything wrong. And you'll find that patients that have the disorder that we're talking about with this patient, what we'll see is that that's often the case. They find that they can't do anything wrong. They have these big plans for themselves, and we'll try to certainly execute them. His stories were disorganized and became more firm when he's questioned. Yeah, I think that's a great observation. Good. Some nervousness. Sure. A nervous laugh. Yeah, exactly. Good. What else? Did you think he was distractible? Good. Yeah, I think so too. Anything else that you guys noticed? So I think this is a good start. Let's clear this and we'll keep going. How about that? He talked about his leg. I think he did too, Stephanie. I think you're right. He did say something, but the thing about it is he, had these flight of ideas and is kind of jumping around. And you'll find that when you interview a patient with a mood disorder, with a psychotic disorder, with any kind of psychiatric illness, sometimes it's very challenging to interview them, and you're going to have to learn to be a good interviewer and get them kind of back on track, and really be organized yourself, because they can really lead you kind of astray with what they're talking about, with this sort of tangentiality. Is this a real patient or an actor? This is actually a real patient from like a 1980s interview. So it was real. And I was like reading the comments to see where it was from. And so something that I came across that was kind of funny is the interviewer, who is a psychiatrist, is like, anything you tell me will be confidential. And then like somebody commented on the bottom and was like, will be confidential until you post it on YouTube 30 years later. And I was like really laughing really hard, but it does help us learn at any rate. And I hope you guys are appreciative of that too. All right, so here's his physical exam. So as we can kind of see here, he is tachycardic. He is well groomed. Is this important, or is that just something we are putting into our physical exam? As we can kind of see, good, self-care. Yeah, good. And the point that I was referring to there, and I made it a point to put it in my physical exam, is that a lot of times with psychotic patients, especially schizophrenic patients, they won't be well groomed at all. They'll have poor hygiene. They'll be kind of unkempt, especially with people of whom are abusing drugs and then have kind of psychosis because of it. You'll see a lack of self-care, and that can tell you a lot about, a lot of things as well. It takes out stimulant abuse, since he would be, Yeah, I see what you're saying. I don't think it rules it out because he's well kept, but I agree with that point to a certain extent. Other than that, he is tachycardic. He has a regular rate and rhythm. His lungs are clear. He has tangential speech. It's rapid and it's pressured. He's very hyperactive. He has grandiose and flight of ideas. So these are all the things that we kind of talked about. He's hyperactive to the point where at the end he was like, I'm getting cramps in my leg, and he like needed to stand up. So he's kind of all over the place, but a very clear picture, I think. Shows he isn't in a depressive episode. Sure, it certainly can perhaps show something like that. All right, so differential. What do we think this this young man has? What would we want to put as our number one? Good, yeah. So it looks like we have some people of whom are familiar with psychiatric disorders. A lot of you said bipolar. A lot of you took it a next step and said bipolar type 1. And we're going to find that that's important to kind of delineate the two, because there is bipolar 1 and there is bipolar 2. Okay, so that's exactly what I said. So I think this is bipolar 1. And what we are calling him right now is something called mania, and we're going to define what mania is, because there is specific inclusion criteria based on the DSM-5. Okay, so other than this, he is distractible. He has grandiose ideas. He's very talkative. He had a decreased need for sleep and increased activity. The increased need for sleep or the decreased need for sleep is pretty important. The increased activity, increased energy level, that's all going to be pretty indicative of bipolar. The one thing that I wanted to make sure to point out to you, and I want you to always remember it, always, the same way that I hope you remember whenever you have a patient with suspected meningitis, you want to rule out increased intracranial pressure before getting an LP. The same thing here. I want you to make sure if you are dealing with a depressed patient that you ask, just because they're presenting to you right now with depressive symptoms doesn't mean that they don't have bipolar depression or bipolar type 2 where they have depressive episodes. Because if you give an SSRI, a selective serotonin reuptake inhibitor such as Celexa that this patient had, you can throw them into mania. And that can be, in and of itself, life-threatening. That can be very, very destructive to the family. It can be destructive to the patient. So I want you to keep that in mind, okay? That's very important. And we'll talk about that later. And there's probably, I think it's so important. I probably wrote a question about it on your quiz. So at least you'll get one right tonight. All right, the next one we can certainly consider, I wrote down generalized anxiety disorder. What from the patient presentation might give you maybe an inclination that this patient could have anxiety? Trouble sleeping, sure, yeah. A little bit of insomnia, certainly. Yeah, energetic laughing, yeah, a little bit of nervousness, fast talking. You guys are all right, good job. So he has less anxiety symptoms. It would be probably more from our physical exam. But what we'll find for generalized anxiety disorder is these people are very, very worried about most things, most days, for really most of their lives. So what you'll find is they're worried about, did I lock the car? This is coming up. If I, don't get to the post office in time, I won't be able to turn into the letter, and then the letter won't make it in 7 days, and all these different things. They're worrying about a lot of things all the time. So really the criteria is most things, most of the time. That's how I kind of remember it, is they're constantly worrying. Hyperthyroidism, we can't really rule this one out. We'll need a TSH to rule in or rule out this one. Then schizophrenia, less likely given that he doesn't have delusions or hallucinations. That's two of the criteria for schizophrenia. But For the assessment and plan, before we kind of move on to the pathology for this one, what are we going to do for this guy? Yeah, so we can do therapy. That's right. We can do cognitive behavioral therapy. That's certainly prescribed medication. Absolutely. You guys are right. And the medication that we want to give this gentleman is a mood stabilizer, which does exactly what it sounds like. And then we want to give a second generation antipsychotic. And we'll kind of go through what each of those is too. Because he's in mania, he's in an acute manic episode, we want to admit him. And what we're going to find is that mania is, we're going to go through the criteria, but it has to be at least going on a week. And if you remember, he's been suffering with this for about a week and a half. So we'll give a mood stabilizer and an antipsychotic. So we'll give lithium and aripiprazole, that's Abilify. And then we'll also monitor the lithium drug levels. They have a narrow therapeutic index. They can certainly cause a lot of things like nephrogenic diabetes insipidus, as well as problems with the thyroid. Lots of different things with lithium, but it is by far the best drug for bipolar disorder and reduces suicide risk in bipolar patients. So, you know, it's a very dangerous drug, but it's a great drug for patients with bipolar. Then, as Trish kind of indicated, we'll want to do cognitive behavioral therapy. And then for the hypertension and tachycardia, we're going to watch that. That's likely due to his bipolar disorder. We're going to see if that goes away, and then we're going to follow up with it. But here's a bipolar disorder, okay, in kind of a nutshell. So what we're kind of looking at, we'll go over this, we'll go over the mnemonic on the left, and that's how I always remember it. But what we're looking for is, and what we're talking about specifically is a manic episode. And what we're talking about is symptoms lasting at least 1 week, and it's a elevated, expansive, or irritable mood, and increased energy or activity, inflated self-esteem or grandiosity, decreased need for sleep. So this guy had a lot of this. He's pressured or talkative. He has flight of ideas, racing thoughts, distractibility, increase in goal-directed activity, and excessive involvement in activities that have a high potential for painful consequences. He didn't necessarily have that, but what we'll see sometimes is an increase for bipolar disorder patients of whom are in mania to have sexual exploitation. So multiple partners, things that are generally dangerous that they wouldn't otherwise do. Their family will usually describe that their activity is just out of the norm for them. So the easy way those were all probably just words to you, but the way that I remember it is by this mnemonic, dig fast. And it's saying the same exact thing. So we need it for 1 week to diagnose mania. That was a terrible writing of 1 week. But 1 week, the D in dig fast is distractibility. So, you know, they're pretty distractible. They're kind of all over the place. Indiscretion, that's what we're kind of talking about in terms of the sexual exploitations. Usually they'll have multiple partners. They'll have grandiosity in terms of their looks. And you'll often see that they'll be out drinking, they're operating heavy machinery while drinking, also having sex while under the influence, things like that. That's the indiscretion. Grandiosity, they'll want to do, you know, very big things. You know, they'll have this major business plan. They'll want to be, you know, the next Bill Gates, whatever the case may be, something that is just not really that plausible. Flight of ideas, sleep, and talkative. So the decreased need for sleep kind of goes in with that idea of increased energy. It's not really like from, I don't know, Elf, whenever he is like, I slept 2.5 hours and I made this rocking horse. It's not really that. It's really they're not sleeping a lot because their brain chemistry is a little bit altered, obviously. All right. So pretty simple in terms of that. It's dig fast. It's an easy way to really remember mania in bipolar disorder. And then when we talk about hypomania, that goes along with bipolar disorder too. We're not really emphasizing that as much, but hypomania is just a lower kind of form of mania itself. That's really how I remember that. So it doesn't really qualify for mania. So it would be bipolar 2. All right. All right. So I want to play this again, and I want to kind of point out some of these. We have one more case. So this might obviously go over our time a little bit, but the next case is a great one as well. Also has another a patient presentation as well. But let me play this and we'll kind of talk through it a little bit.
Tell me something about the events that took place prior to your admission to the hospital.
Okay. It was 4 o'clock in the morning. I was working out for the Olympic team. Can you dig it?
Why were you doing that?
Because, well, I had this buddy who got thrown out of the place where I was living. And he was supposed to meet me in Hallsville Park. And it was 4 o'clock in the morning and he didn't show up, so I figured that I would work out. And then they got me on a DOC, disorderly conduct, ?
What were you doing when you were working out?
Running back and forth, basically checking out the court, checking out the moves that I'm going to do when I get into the Olympics.
Are you already on the Olympic?
No.
You're not on the team?
No, I'm not on the team.
So you're just trying out. Is that what you're trying to do?
Yeah, trying out.
What makes you think you'd be eligible for the Olympics?
Because I'm a damn good basketball player and I had never done nothing wrong in my life before. And so I think I can make the Olympic team.
Why do you say that?
Because I'm in good shape and I got Olympic abilities. I know I have.
What do you mean by Olympic abilities?
Olympic basketball skills. I know I got Olympic basketball skills. I'm better than Oscar Robertson.
Earlier, you said you could join the Olympics because you'd never done anything wrong and you were in good shape.
Like nothing I'd be ashamed of. See, like nothing I'd be ashamed of. Like if I did something wrong that I'd be ashamed of, I think it'd be hard for me to join the Olympic team. Don't you believe?
All right, so that was a little bit of a kind of recap of that one. As you can kind of see from that, just, had a lot of grandiosity, a lot of, I can join the Olympic basketball team. I have this ability to play, all of these things. He had a lot of activity. He even said, he's up at 4 a.m., checking out the court. So that, obviously is increased activity and a decreased need for sleep. He's, even pretty talkative. And later in this video, we start to see that he gets a little bit distractible, very kind of characteristic for bipolar disorder. If we look back at his history, we say, okay, this has been going on for a week and a half. He has, a lot of this criteria for dig fast. So as we can kind of see, this is, very, very characteristic for a manic episode. Okay, so let's talk a little bit here about, before we kind of go on, a little bit about risk factors. So someone kind of alluded to this, but a family history, increased stress or trauma can be a risk factor, and certainly substance abuse. Other than this, we are going to treat this patient with mood stabilizers. So what we're going to talk about is lithium primarily, but there's 3 other ones that we can use that are anticonvulsants, so that are also anti-stabilizing medications. So carbamazepine, valproate. Valproate can cause neural tube defects if used in pregnancy, so we don't want to use that one. Lamotrigine can cause Stevens-Johnson syndrome. Carbamazepine can cause agranulocytosis, which is a lowered white blood cell count. And then lithium is a great drug, but it has a low therapeutic index, meaning only a little bit of the drug causes a very strong effect. Or in other words, even a low, it only takes a little bit of the drug in order to cause adverse effects. It does have endocrine side effects on the kidney and on the thyroid, and it's contraindicated in pregnancy because it causes congenital heart abnormalities. It's called Epstein's anomaly, where you get basically atrialization of the right ventricle. So basically the right ventricle kind of extends into the atrium extends into the right ventricle. There are antipsychotics we can use, but those are, obviously less important for our discussion here today. We'll do the poll at the end, obviously, but let's keep going here and we'll kind of roll right into our next case. Okay. So here's another video for you guys. So kind of take note of the things that she's saying and what might be important.
Do you want to tell me a bit more about what's been going on?
I just things seem to be piling up.
Right.
I just don't seem to be coping with things.
Right. Okay.
With kids and things.
Right. Okay. Would it be okay, Alison, for me to ask you a few more detailed questions about how you've been feeling? Okay. Well, if we start with asking you a bit about your mood, how have you been feeling in yourself?
I say a bit fed up. Wake up in the morning, everything just seems very black.
Right.
It's just like swimming in treacle, really. And I just don't. I think by tea time the kids get home. Been having a fairly decent conversation.
Right. And can I just check, Alison, when you say things feel very black, do you mean you feel very miserable?
Fed up, miserable.
Okay. And what about sort of feeling tearful? Has that been happening?
I dropped some sugar the other day. I just burst into tears.
Right. Okay. So is it the slightest thing that would make you feel tearful? Things that perhaps wouldn't ordinarily bother you?
Yeah.
Right.
My sister's noticed as well.
Right. Okay. So you've been feeling very low, and with episodes of tearfulness.
Yeah.
What about other things? What about your energy levels? Are you managing to keep up with things?
I used to do a lot with the kids. I used to go swimming, playing, but now I just spend the day on the sofa, really, unless I have to go to work.
Right. And just remind me, what is it you do for your job?
I work in a supermarket.
Right. So how have you been managing at work?
I'm not been going in as much because I just feel so exhausted. But I mean, we're just not. The supermarket's been taken over and they've cut the wages.
Right.
And I'm having problems with the bills.
Right.
And it's like the catalogues, they're just writing me letters.
Mm-hmm.
The kids, they want all these new games and stuff.
Yeah, sure.
It's just,
I think things. Okay.
I think that from that, you are able to get a good, hopefully, a good impression of what might be going on. But our vignette, this is a 39-year-old female that presents to her PCP at her sister's request for low mood. She notes that she's a bit fed up and asks, and when she wakes up every morning, everything appears black. This has been worsening over the past few months, but has been apparent over the last 2.5 years. Her energy level is low. She's been more tearful. She's had trouble sleeping, difficulty falling asleep, and terminal insomnia, meaning she's waking up early in the morning. So lots of problems with her sleep. She notes decreased appetite and concentration. So similar to the last time, a few questions for you all. What differential diagnoses are we going to consider in this woman? go ahead, think broad, that's okay. Major depression, sure, yeah, absolutely. I think that, yeah, anxiety as well. I think we can think about anxiety, certainly. What else? I alluded to it when we talked about the last patient in terms of bipolar disorder, but don't forget that we want to include medical causes of these things too. It's very, very important. Major depressive disorders, certainly. Nervous, yeah, hypothyroidism, exactly. If you remember from the thyroid lecture, a lot of hypothyroidism comes as kind of low energy, depression, whereas hyperthyroidism is increased energy, anxiety, palpitations. Iron deficiency, maybe, yeah, we could think anemia because that causes low energy level as well. What else? What else do we want to think about? Think neurologically. We kind of checked off endocrine, we checked off psychiatric. Can ask about other hormones. Yeah, good. We can consider postpartum depression. Yeah, we want to ask about, good. And that comes into, you know, what other questions do we want to ask? You know, how old are your children? That is certainly very important to ask. Menopause, good. Exactly. Yeah, we'll want to definitely ask about menopause and the symptoms then as well. What about neurological? I'm rounding back to neurological again. What do we want to ask in terms of neurological questions? So this is perhaps far-reaching, but there is strokes that can cause depression. Yeah, good. Parab said it. So a left MCA stroke, the middle cerebral artery, can cause depression. I mean, she's a little bit young as well, but other kinds of dementia, Parkinsonism, Huntington's disease, and other chronic illnesses are risk factors for depression. Fibromyalgia also causes depression. A lot of these chronic illnesses, cancer, a lot of other things, as a family member with cancer, increased stress, any of these things we'll want to ask about as well. But the one to kind of take note of is stroke can also cause depression as well. What else? So medical etiologies, we certainly talked about that as well. What elements are important from her history? What did she tell us that we want to kind of keep track of? So can this happen to a person without a history of depression in their family? Yeah, it certainly can. So, you know, you don't have to have a history of depression in your family in order to have depression. That is, you know, that's not kind of, you know, all inclusive. You don't have to have the family history. So what did this patient tell us that is kind of important, or we want to kind of keep in mind? Yeah, interfering with her work and home life. Good, good. Problems with bills, certainly. Yeah, so she has increased stress. What about the way she's speaking? I noticed that very quickly. Symptoms worsened over the past 2.5 years. Yeah, the time is very important. Very slow and deep sighs. There's one thing I'm looking for. No eye contact. Yeah, certainly. Good. Low self-esteem. Yeah, I think that comes along with the no eye contact as well. Great. There's one thing. I think you guys are missing it. Yeah, good. She's tearful on exam. That's something to keep in mind as well. A lot of times, and there's one other thing that she said that we certainly want to get more information about. She said that she's a bit fed up. What do we need to ask her? Yeah, good, Hope. We want to ask about suicidal ideation. I know that there is kind of a stigma that if we ask about it, it's going to give them the idea. There's been studies that sort of disprove that. That's not a thing. Just because you ask it doesn't mean that you're going to plant that kind of seed in their head. Ask about it. You could save somebody's life. So if she says, you know, I'm a bit fed up, the way I ask about it, harsh language that you know, I don't ever ask, do you want to kill yourself? I don't you know, phrase it like that. I say, have you ever thought about hurting yourself or hurting others? I think that people get the idea from it, and it also includes the idea of self-harm in the way of cutting. A lot of younger adolescents do that to kind of have an outlet for their stress and anxiety. Older people also do it as well, but it also encompasses that when you ask that. In addition to asking about them, I always ask if they want to hurt others as well. That's homicidal ideation. And I always ask that in psychiatric patients, because they may have that idea as well. And it's important for the safety of others as well. So good, that is certainly something that we want to ask. So we kind of talked about it a little bit, but like the last patient, let's brainstorm together, or go ahead and you know, really lay out what findings were important from this patient's interview. Difficulty managing life, yeah. All right, what else? I know some of you guys said low self-esteem, low energy. What about her concentration? Yeah, decreased appetite, good. She did mention decreased concentration. She's tearful. What else is important? If you guys had to write up your note, what would you put in kind of your physical exam for psychiatric? I don't think she actually mentioned why, Stephanie. I'll let you guys watch the rest of the video a little bit longer when we kind of go through the criteria for what this patient has. But yeah, so unable to, so what we can say is no mood reactivity. Sometimes what we'll find in atypical depression is that those patients have mood reactivity, where, you know, they are able to enjoy certain things, albeit, you know, for a short period of time. She had insomnia, good. And we'll say suicidal ideation, maybe. We'll put a question mark. We didn't have a chance to ask about it. Lack of confidence, good. And the symptoms for 2.5 years. So it was a while. So you guys kind of have, I think, a good idea of you know, what makes this patient, you know, having the disorder that is going on. But here's her physical exam. It's always important to include this, and I always do it in my notes. I always put like depressed affect or whatever, especially if they are depressed, and especially if you're giving them a medication for it. It really justifies why, because like other things, you know, in the physical exam, you know, for instance, for you know, abdominal pain and nausea, you push on their belly, they have abdominal tenderness, then you want to order you know, a CT or an ultrasound. Your physical exam findings justify what you're ordering. Same thing in this regard. Your physical exam findings should justify why you're prescribing or ordering the things that you are. So if you don't write that the patient is depressed, or, you know, you put in something that would indicate the opposite, it may contradict itself. So you want to put that the patient is depressed, appears her stated age. Sometimes when patients have chronic health conditions, it can appear older than their stated age. You don't want to tell them that may insult them, but just keep that in your note. The patient's bradycardic. She has a heart rate of 51. Regular rate and rhythm, her lungs are clear. She's tearful on examination. I'll always write that if they are. I'll put tearful on examination, or depressed, or I also like to put, if their speech is slowed, I'll put psychomotor slowing, like they're having a hard time articulating themselves, they're having a hard time with their thoughts. That's called psychomotor slowing. The old term is you might still see it in some textbooks and some sources. The old term was psychomotor retardation. That's, fallen out of favor. It's usually psychomotor slowing. And then the opposite is psychomotor agitation. So our last guy that had bipolar disorder, he might have a little psychomotor agitation. And then suicidal ideation. So there we go. We asked her, but without a plan. And what that means is if someone comes to you and you say, do you have ideas of hurting? Have you ever thought about hurting yourself or hurting others? And then she says, I have thought about, hurting myself or killing myself. And then what you would ask then is, well, do you have a plan or of how you would do it if you were to kill yourself? And these questions can be hard to ask. You usually get more comfortable with it over time. You'll find that. But the point is, it kind of will determine whether you need to contract for safety or submit this patient. If this patient comes to you and says, I want to kill myself, I have, a revolver, I brought it in my backpack, it's in my car, you probably want to admit this patient. Because her safety is at risk. If she said, no, it's just kind of thoughts, and I do have a plan, I would get a helicopter and I would fly it and then crash it. And then you say, well, do you have a helicopter? And then she says no, then that's a less realistic plan. Maybe you contract for safety at that point and say, okay, well, if anything happens, here's my number, call me and let's talk about it first. That's what contracting for safety is, okay? All right, so moving on. What is our differential diagnosis at this point? What do you guys think? Depression? Good. Absolutely. She could have bipolar type 2, absolutely. And it's very important to ask about if she's ever had mania. And that's an important question to ask. Good, Natalie. What about depression? Do we think that she may have a subtype of depression? So we have somebody for major depressive disorder. So I say persistent depressive disorder. The reason I say persistent depressive disorder is because it's been greater than 2 years. All of you that said depression, you're absolutely right. It's just a different qualifier because it's been greater than 2 years. There's another qualifier called atypical depression. That's usually when the patients get hyperphagia, so they eat a lot. They have latent paralysis, meaning their limbs are like really heavy. That one is just a qualifier just like this one is. So this is due to the prolonged symptoms. We want to get a TSH to exclude this diagnosis just like we did for the last one. And then, as Natalie kind of referred to, we can't really rule out bipolar right now, and we want to ask more questions to make sure. And anytime I prescribe any antidepressants, I always ask, have you ever had, and I don't ask them, have you ever been diagnosed with bipolar disorder? Because sometimes when you throw these diagnoses at these psychiatric diagnoses, they'll be like, well, no, I don't have bipolar. And then they get nervous, and you just don't do that. The same way you wouldn't, throw a cancer diagnosis out at them and say, you may have cancer. I don't do that. I usually ask, have you ever had increased energy? Have you ever had a decreased need for sleep, or find like you have more activity and you're able to do more things? That's usually what I ask. And then if they say no, I always sleep the same amount, then I usually rule that out. But if they say, yeah, sometimes I only need like 2 hours of sleep and I get a lot of stuff done, and then I usually will ask, and I learned this from a great preceptor I was just with, I usually ask about spending sprees, because I think that is pretty indicative for a lot of people, and especially in bipolar disorder. You say, well, you know, when you have this increased energy, do you feel like you can, you know, do anything, conquer the world, and do you go on spending sprees? And if they say yes to all that, you know, maybe we don't prescribe a SSRI and instead prescribe something else that won't kind of throw them into mania. Okay. So they didn't have manic or hypomanic symptoms, but we can't rule it out just yet. Maybe an adjustment disorder with depressed mood, depending on if there was any major life stressors. We didn't really get that inclination, but maybe it's an adjustment disorder. Adjustment disorder is, you know, exactly what it sounds like. The classic vignette is like dropping a kid off at college and then them having, you know, anxiety and depression. And usually that's within 3 months of the onset of the stressor. Okay. All right. So assessment and plan. What do we want to do for this patient? What are we going to, what's her plan? So therapy, yeah, exactly. There's a lot of studies that show that medications or cognitive behavioral therapy is not as effective as both kind of synergistically. Both of those together are immensely effective. Cognitive behavioral therapy and medication. Depressive disorder, same treatment as regular depression. We can give a SSRI, and what we want to do is we want to start out the lowest dose possible. We're not going to bombard her system with antidepressants. We want to monitor for side effects, and then we want to, you know, have her come back and reevaluate her symptoms. And in terms of brain stimulation therapy, that's a good thought. What we use electroconvulsive therapy for is pregnant patients and patients who have failed other medications. And then also very depressed patients who are admitted that won't eat or who won't eat or drink. Okay. And then for Natalie's question, if she wasn't bipolar 2, would you prescribe fluoxetine or Wellbutrin XL? Yeah, if we knew that she wasn't bipolar, you can give really any SSRI. And if she, and good point with the Wellbutrin, I was just going to talk about that. I like bupropion Wellbutrin for patients of whom are also trying to lose weight, because one of the side effects is weight loss and decreased appetite. So that might be beneficial for someone of whom is trying to lose weight. Sometimes you can use those side effects positively to, you know, individualize the treatment for patients. Okay, good question. And then if the patient is improved, we'll leave the dose. And then if they're not improved, then we want to change the dose. And do you guys know what the time period is that we need to follow up with this patient? Do we have them come back a week? 2 weeks, 3 weeks? Yeah, about a month. Good, Stephanie. It's about 4 to 6 weeks. Usually we say about 6. 4 to 6 is good because it takes time for the plasticity of the neurons of the brain to change. So it takes a little bit of time, and that's why we follow up in about 6 weeks. So if the patient is not improved, we can increase the dose or change another one. A lot of times, a lot of treatment of depression is trial and error, unfortunately. The drugs that work well for a lot of people may not work for some people. Tricyclic antidepressants have fallen greatly out of favor because they're very dangerous drugs with lots of side effects. They cause QT prolongation of the ECG. And for patients that are depressed and of whom are suicidal, they can very easily overdose on tricyclic antidepressants. So there's very few things that tricyclics are kind of first line for. Sometimes they're first line because of their adverse effects, their anticholinergic effects. They might be used for enuresis, for bedwetting, because it causes retention of urine. But they're usually not first line for depression. If you've failed a lot of other drugs, we might consider them, but usually not first line for depression. So we'll want to do cognitive behavioral therapy, a little bit of counseling. If they're used for some other purpose, can we see mania as a side effect? Yeah, you're right. So if you're using them for like neuropathic pain, for say somebody has fibromyalgia or diabetic neuropathy, and you're using a tricyclic for that, even then tricyclics are not really first line for that either. Usually it's like pregabalin or gabapentin, or even duloxetine, Cymbalta. That's even more common than tricyclic antidepressants. Tricyclic antidepressants, TCAs, are just very dirty drugs, and a lot of people kind of stray away from them for that reason. But yes, they can, antidepressants like TCAs can throw you into mania, depending. Okay, so then we want to consider cognitive behavioral therapy counseling. So here is one of the last slides. I know this is taking a little while. I want to be sure to tackle both of these things for you. I like this chart, but then when I was reading through it, I found it was wrong. So excuse the text over the one they put forward. It's definitely 5 in the DSM-5. So what you need is a depressed mood or anhedonia. And what anhedonia means is loss of interest. If they say, you know, my Earl Grey tea makes me happy, and now when I drink it, I'm not happy anymore, that's anhedonia. Or if they say, you know, taking my kids to the park daily, you know, used to bring me the most joy, and now doing it, I just could care less. That's anhedonia. But what we want to see is sleep disturbances, psychomotor agitation, and here's that word that we has fallen out of favor. We call it really slowing. We also look for fatigue. We look at problems with executive function, increased guilt, suicidal ideation, and then here's where it can be a part of unipolar depression, bipolar depression, either 1 or 2. And the easier way, instead of this, all these words, the way that I remember it is the mnemonic SIG-E caps. And so what we see here is SIG-E caps. And what we look for is depressed mood or anhedonia plus 5 of these. So sleep changes. So changes in sleep meaning they sleep more, they sleep less, they have trouble falling asleep, they wake up early, decreased interest, increased guilt, decreased energy, decreased concentration, agitation, psychomotor changes, or suicidality. So as you kind of can recall, and we'll watch the video one more time, our patient had a lot of these things, and the psychiatrist did a really good job. And once you kind of know these things, you know exactly what she's asking for. And when I ask depressed patients this, I always usually ask in this order, I won't forget, because I remember SIG-E cap. So I say, okay, how has your sleep been? And they say, well, you know, I sleep terrible. I sleep, you know, maybe a few hours per night. I just can't fall asleep, even though I'm so tired. Then you say, well, do you still enjoy doing the things that you used to do? I know you mentioned you like football. Do you still enjoy playing football? And then they, you know, will answer. Do you feel guilty? And then they'll answer that. You know, how's your energy level been? How's your concentration? Do you feel more agitated with other people? Are you having, you know, trouble thinking clearly, like brain fog? And then you can ask about suicidal ideation as well. Okay, so that makes it a lot easier instead of all of the words in the chart over there. But let's watch this one more time. This is one of my very last slides other than the survey, but let's listen to it again, and let's kind of point out the things that she says that kind of go along with SIG-E caps that we just learned.
Do you want to tell me a bit more about what's been going on?
I just think things seem to be piling up.
Right.
I just don't seem to be going through anything.
Right. Okay.
The kids and things.
Right. Okay. Would it be okay, Alison, for me to ask you a few more detailed questions about how you've been feeling? Okay. Well, if we start with asking you a bit about your mood, how have you been feeling in yourself?
I'd say a bit fed up. Wake up in the morning, everything just seems very black.
Right.
It's just like swimming in a treacle, really. And I think by tea time the kids get home. So I've been having a fairly decent conversation with them. But...
Right. And can I just check, Alison, when you say things feel very black, do you mean you feel very miserable?
Fed up, miserable.
Right. Okay. And what about sort of feeling tearful? Has that been happening?
I dropped some sugar the other day. I just burst into tears.
Right. Okay. So is it the slightest thing that would make you feel tearful? Things that perhaps wouldn't ordinarily bother you?
Yeah.
Right.
My sister's noticed as well.
Right. Okay. So you've been feeling very low, and there's episodes of tearfulness.
Yeah.
What about other things? What about your energy levels? Are you managing to keep up with things?
I used to do a lot with the kids. We used to go swimming, playing. But now I just spend the day on the sofa, really, unless I have to go to work.
Right. And just remind me, what is it you do for your job?
I work in a supermarket.
Right. So how have you been managing at work?
I'm not been going in as much because I just feel so exhausted. But I mean, we're just not. The supermarket's been taken over and they've cut the wages.
Right.
And I'm having problems with the bills.
Right.
And it's like catalogues. They're just writing me letters.
Mm-hmm.
You know, the kids, they want all these new games.
So I think things are really difficult all round. Okay. With all this going on, how are you sleeping, Alison?
It takes me ages to go to sleep. I used to read a book.
Right.
And just drop off.
Right.
But now I just spend my time looking at the clock.
Right.
So it goes round.
So from actually getting off to bed and getting off to sleep, how long is that taking?
A couple of hours, probably.
Right. Okay. Once you're actually asleep, are you waking up much during the night?
I wake up about, last night I think it was about 4 o'clock.
Right.
I woke up.
And can you get back to sleep from that time?
No.
And then when you're actually getting out of bed in the morning, are you still feeling tired at that point?
Just exhausted. I feel like my brain's not been switched off.
Right.
And I'm just exhausted the next day.
Okay. What about eating? What's your appetite been like while you've been feeling like this?
I used to have quite a weight problem, but the last couple of months, I mean, it's just a bit looser.
Right. Do you know how much you've lost?
No. The kids come in from school and they make their own stuff, and I just don't bother really.
Okay, so your appetite's gone down as well. What about things like concentrating in your memory, both when you, watching TV at home or out when you're out doing your job?
Well,
how have those things been?
I mean, pretty useless with the kids. I've got the swimming money last week and
right.
PE kit and parents' evening.
Right, okay.
I just...
All right, guys. So that was a little bit more, as you can kind of see, she talked a little bit about concentration, appetite, energy. You could just tell she's very down, very depressed. So a lot of these things that she, or that is in Siggy Cap's sleep changes, she had decreased interest. It sounded like she was guilty. They didn't really ask about guilt up front, but just by talking about how she dropped the jar of sugar, you could tell that she felt guilty about it. So I would consider that guilt. She has decreased energy, decreased concentration, doesn't really sound agitated, does have some psychomotor slowing. and maybe the suicidal ideation, but a lot of these things are positive. She was positive for both depressed mood, also positive for anhedonia. So she meets the criteria here for major depressive disorder. It does qualify as persistent depressive disorder because it's been going on for 2.5 years. So good job with that, guys. In terms of risk factors, we want to think about family history of psychiatric disorders, substance abuse. It can change the plasticity of the brain, certain drugs, chronic illnesses, as we kind of referred to before, increased stress or trauma, and medication side effects, okay? And then this should be my last slide, but we talked a little bit about antidepressants, but what I want to kind of show you is, yes, there are lots of antidepressants. There's the tricyclics. We talked a little bit about those. There's SSRIs. We have SNRIs, so selective norepi or serotonin norepi reuptake inhibitors. SSRIs are selective serotonin. We have MAOIs, which really aren't used a lot. We have serotonin modulators and atypicals like bupropion, which is Wellbutrin. But what I'm really showing you here is, here's kind of the synapse of a neuron here in the brain. And what we see is in the kind of theory of depression is what's called the monoamine hypothesis. And that is that depression is the result of monoamines like serotonin, dopamine, norepinephrine. And so what we find is when we inhibit the reuptake, we inhibit, the reuptake of basically these are released from the neuron and then they go back up into the neuron. When we inhibit the reuptake of them, more are available in the synapse between the neurons that affects the chemistry of the brain. And that's what we're pinpointing with these drugs. So it makes a little more sense now, doesn't it? So we're inhibiting the reuptake of serotonin. And so as a result, more serotonin is available in the brain for the synapses, which in turn affects the mood and affects it affects the basically the neuroplasticity and the way kind of people interact with their world. So that's really what I wanted to show you there. There are a lot of drugs there. For our patient, we might want to consider, I would say, SSRIs. We can consider SNRIs. We don't really want to use an MAOI. Those are rarely used, and not a tricyclic. These are not really used as much. Trazodone is used for sleep. That might help her sleep. But I would choose maybe bupropion or an SSRI or an SNRI. But let me put up our poll here. Let me relaunch this for you all. Please take a couple seconds and throw your answer there into the poll. All right, so let me share this with you. Looks like a lot of you have said, some, and some of you even said, a lot. I'm very humbled by that. I hope you guys did learn a lot. Psychiatry, very, very interesting field. I imagine that some of you are budding psychiatrists. You guys did great. Did we go over the most important question to ask in depression? In my eyes, yes. So there is sort of subjectively what a lot of important questions are in depression. But I hope that you guys learned something tonight. It's always a pleasure when I get to spend my Wednesday evening with you guys. I'll stick around for any questions that you guys may have. And be sure to kind of fill out the SOAP note and then fill out the quiz. And let me know if you have any questions at all. I will stick around for a little while, but otherwise it's been a pleasure. Thank you guys for your attention.